Bino has a special award to announce, and then we will introduce our speakers.
Okay, good morning, everybody. You know, it's a real delight to honor one of the luminaries in our department. So there's two messages about Jim Bale today. So the first is that he is the recipient of the 2019 Hauer Award, which is the highest award that the Child Neurology Society offers. I'd just like to read a paragraph from his nomination letter. The Hauer Award is a prestigious honor for a pediatric neurologist who exemplifies scholarly activity, outstanding teaching and mentorship, and service. We have been very fortunate to have Dr. Bale as a member and leader in our division, department, and university. We have benefited from his excellence. While Dr. Bale is already well known in the national community, we think it is fitting that he will receive the highest honor of the Child Neurology Society. So Jim, we're delighted that you're going to be the recipient of the Hauer Award. And in addition, many of you may have heard that Jim retired, but he's still working here. It's really my honor to present him with the Emeritus Certificate. So at Utah, it's a big deal to be appointed to the Emeritus faculty. So I'd like to read a little bit about that as well. And again, because Dr. Bale is a luminary, I think it's worth that we hear a little bit about him. So Dr. James F. Bale received his undergraduate and medical degrees from the University of Michigan and completed residency training in pediatrics and child neurology at the University of Utah, where he trained with Drs. Lowell, Glasgow, and Patrick Bray. He then pursued postdoctoral training in pediatric infectious disease and neurovirology at UCSF before accepting a faculty position at the University of Iowa in 1982. He came back to the University of Utah Department of Pediatrics in 1997. He served as the Vice Chair for Research and the Vice Chair for Education in the department. He subsequently served as the Program Training Director for our Pediatrics Residency Program from 2004 to 2014. In that role, he is truly revered and adored by his trainees. His influence in medical education has been extraordinarily broad. It's a real honor to present you with this certificate, and you will always have a home here. Thank you, Jim. And now Karen's going to introduce our grand round speaker.
Good morning. For you, those that don't know me, I'm Karen Vushai. I am the Division Chief for General Pediatrics. In 2015, the Department of Pediatrics and the Division of General Pediatrics, in collaboration with the Utah Department of Health, established the University Developmental Assessment Clinics, which we affectionately called UDAC. UDAC has two major components. The first is Longitudinal Developmental Follow-Up Program, which currently involves the Neonatal Follow-Up Program and the Pediatric Heart Center Neurodevelopmental Program. The second is the Child Development Program, where children are assessed for developmental and behavioral concerns. And now, since 2017, UDAC has been operating solely within the Department of Pediatrics at Primary Children's Eccles Outpatient Building. Unlike any other program in the state, children with developmental concerns are assessed by the UTAC multidisciplinary team, all of whom have enhanced developmental assessment skills. Pediatricians, nurse practitioners, psychologists, occupational and physical therapists, and a speech-language pathologist all serve the developmental needs of over 2,000 new patients each year. Dr. Sarah Winter, your first speaker today, is the medical director of UDAC. She received her MD at the University of Minnesota and completed her pediatric residency and chief residency there. She did her fellowship in developmental pediatrics at Emory and is the only board-certified neurodevelopmental pediatrician on our faculty. She's an expert in the evaluation of children with developmental delay and is an internationally known expert in the diagnosis of infants and toddlers with cerebral palsy. This is evidenced by her serving in the presidential line of the American Academy for Cerebral Palsy and Developmental Medicine and on the executive committee of the International Alliance of Academies of Childhood Disability. Dr. Nguyen received her MD from the University of California, San Diego School of Medicine. She then did her pediatric residency and chief residency at the Floating Hospital for Children at Tufts Medical Center in Boston. She gained extensive general pediatric practice experience as a staff pediatrician for Group Health Cooperative in Seattle, Washington. I successfully recruited her into our Gen Peds division in 2015. She has completed a certificate program to enhance her skills in developmental assessment under the guidance of Paul Carbone and Sarah Winter. She also has participated in the Utah Regional Leadership Education in Neurodevelopmental Disabilities program, also directed by Sarah Winter. She's an integral part of the UDAC Child Development Program and its innovative approach towards addressing the needs of our pediatric community to get access to high-quality developmental assessments. Please join me in welcoming Sarah and Q.
Thanks so much, Karen. I appreciate that. So, welcome to Grand Rounds this morning. We are going to highlight two areas of the developmental assessment clinics. And as she said, I'm Sarah Winter, and I'm the medical director of the clinics as a whole. And Dr. Nguyen is an academic general pediatrician, both for the University Pediatric Clinic, where she has her primary care patients, but also with us at the UDAC, and we're just so thrilled to have her. So already did the safety moment, and Q and I would like to say that we have no disclosures to report. We want you to walk away with two things this morning. If you walk away with more than that, good for you. But generally speaking, we can only learn two, maybe three things. One of the things we want you to really understand is that pediatricians can serve as first-tier diagnosticians for autism, and Q's going to describe how we have done that. And then the second thing is I want you to be aware, you're not going to remember all the fine details, but be aware of our data that we have from the neonatal follow-up program. So those are your two goals for this morning. But to do that, I'd like to provide an overview, and Karen gave you a bit of that as well, but a perspective on where these two items and these two pieces of knowledge that we want to give to you are embedded. They're embedded in our program, and we are just really excited to be able to present this information to you at this time. As she said, it's a program that's within the Division of General Pediatrics, within the Department of Pediatrics. And we started in 2015, but except for the Heart Center Neurodevelopmental Program, this is really an extension of what's been done at the Utah Department of Health and the Bureau of Children with Special Health Care Needs. So it's a continuation of where you used to send your patients, and many of us are actually the same people. I'm looking at Paul. So, it's not radically different, but we have extended and expanded our services. We do our work with a tremendous amount of fiscal and administrative support from the Department of Pediatrics. And we do this with a tremendous team of specialists. There isn't any one field that can fully, truly understand the many expressions of development that a child can have. So it's essential that when you assess a child's development, it be done in this multidisciplinary and often interdisciplinary fashion. It really takes specially trained people to do the kind of evaluations we're talking about. So today, we're really going to focus in Q's talk about one particular project within the Child Developmental Program. And then you're going to hear a bunch of data and hear a larger section about your second objective, which is to understand what we're doing in the neonatal follow-up and some of our developmental outcomes. But I don't ever want anybody to forget our mission. We are going to present research to you, but our mission is to support the children, the families, and you all as medical providers in seeking expertise in the evaluation and the treatment of developmental problems. I really view, and I think many of you are in complete agreement with this, that the data, the research, and the many educational activities we do at the clinic support the essential mission of supporting children and families. So it's first and foremost for our children and families that we do our work. The Child Developmental Program is really set up to assess, the many developmental issues that families, or the developmental concerns that families bring to us. The particular presentation you're going to hear from Q is specifically about autism spectrum disorders, and it's true that the vast majority of concerns that we get in the Child Developmental Program are the question of, does my child have autism? But recognize that sometimes the child doesn't, and then sometimes that isn't the question that we're being asked. So we are there to evaluate any developmental concern, be it motor, language, behavior, emotions, and cognitive issues. But you're going to hear mostly today about the question of, does my child have autism? So with that, we're going to introduce to you Dr. I'm going to try and say her name, Quang-Tuyen Nguyen, but we call her Dr. Q.
Thank you, everyone. I have a little bit of a cold, and so if my voice cracks at times, please accept my apologies. So we opened in 2015 and found that despite being one of the largest developmental centers in the Intermountain West, we still had more referrals than could be handled by our team. And this, unfortunately, isn't unique to the field of developmental pediatrics. In fact, across the country, evaluations can take upwards of a year, and part of this is because of the multidisciplinary nature of our evaluations involving speech pathologists, occupational therapists, physical therapists, audiologists, developmental pediatricians, and psychologists. Some insurers also require, in addition, PhD-level psychology-administered testing in order for a child to access services, and this complicates the picture. What troubled us in particular at UDAC was that the long wait time impedes the child's start for therapy. And so there's been evidence, especially in some developmental disabilities such as autism spectrum, that earlier therapy gives you better outcomes. In 2014, Orenstein et al. Found that optimal outcomes in autism, meaning the child no longer met criteria for autism, was often achieved if ABA had been established before 36 months of age. Unfortunately, across the country, the average age of diagnosis is closer to 52 months, and so well beyond that. And so that was one of our targets. There have been multiple attempts to address these issues across the country. There have been groups that have set up speech pathologists and developmental pediatrician dyads. There's been efforts to shift visits to more diagnostic visits in order to increase the access for services. There has been advocacy to increase what we call presumptive eligibility because the evaluation process is so long and can take forever to do to start therapy. What we focused on was some of these access issues. Utah already struggles even more than some of the other regions of the country because there are only 2 developmental pediatricians in the state. You heard from 50% of our staffing pool, Dr. Winter. And according to the 2017 AAMC Utah Physician Profile, there's 1 developmental pediatrician for every 460,000 children in Utah. To kind of put this all into perspective, we have 1 interventional cardiologist for 117,000 patients, 1 general surgeon for every 17,000, and 1 pediatrician for roughly 2,000 pediatric patients. To make this even worse, we know that according to the American Board of Pediatrics, 1/3 of the developmental pediatricians are going to retire in the next 3 to 5 years, further exacerbating this shortage. So our focus was in exploring an alternative model. We started a quality improvement pilot project in 2016 using general pediatricians as a first-tier diagnostician. We compared our alternative model to what had been our traditional model and reviewed our models for feasibility, reliability, as well as patient and family satisfaction. What our traditional model What our traditional model had set up was a series of multidisciplinary evaluations with audiology, speech, occupational therapy, physical therapy, and pediatrics according to the needs of what had been expressed in a referral packet. Subsequent to that, all of our patients saw our psychologist in 3 visits and a total of at least 8 clinical hours. This would involve an intake, examination, and testing, and then a feedback session, and then a diagnosis, if appropriate, at the end. What we focused on in our alternative model was early childhood, so ages 2 to 5. We provided autism-specific training for our pediatricians, covering a number of different second-level screeners, as well as support through a multidisciplinary conference held on a weekly basis. We tracked our physician diagnostic confidence, and we reviewed 244 records from 2015 and 2016 within each model type, and of course always surveyed families to make sure that there had been no attrition in satisfaction and quality. In our alternative model, patients saw audiology and speech evaluation and occupational therapy and physical therapy as appropriate. The pediatric visits were expanded from 1 hour to 2 hours and would involve history, examination, testing, as well as feedback, and then a diagnosis if appropriate. For those patients who it was unclear if this patient had autism or not, they were subsequently referred on to psychology for diagnostic clarification. Things we measured included the time to diagnosis, fees charged, the diagnostic agreement between MD and psychology, the feasibility of alternative model, and parent satisfaction questionnaires. So what we had was 101 patients who underwent the pediatric evaluation, and 57 patients were diagnosed with certainty as having autism or not. There were 44 patients, or roughly 44%, who went on for a further evaluation with psychology. What we found was that the time to diagnosis and the total charges were significantly different, with a reduction in almost 44% in time to diagnosis as counted by days. So in our alternative model, we were able to reach diagnosis for these families in 85 days, whereas in our traditional model, it took us 152 days. Total charges also dropped by roughly 33% as well, and so went from $1,800 roughly down to $1,200. In some cases, patients were seen by not just the pediatricians, but also seen by psychology as well. And this may be for a number of reasons. Some insurers required further psychology evaluation, so that provided a ready sample. There were other cases where patients and families really felt unsure about the diagnosis and wanted a second opinion. And so with this sort of natural cohort, we were able to study our diagnostic certainty. With each pediatric evaluation, there was a 4-point Likert scale that the pediatricians answered in terms of very, very definitely autism, somewhat likely to be autism, somewhat unlikely to be autism, and definitely autism. And so we used that scale and we looked at our certainty, which is not autism, and definitely autism. And when we compared those 14 cases, we found 93% agreement with the psychologist. In 4 cases of definitely not autism at all, we found 100% agreement between our psychologists and our pediatricians. In reviewing our patient satisfaction scores and family satisfaction scores as well, we found that there had been no attrition in satisfaction, and in fact, patients really felt that our care was still very much family-centered, that there was shared decision-making, and that they were satisfied with our diagnostic process. And so we were pretty happy with that. Using the results from this research, we were able to take it further and push it to the advocacy and policy level, and have subsequently affected the Utah Medicaid state policy to increase access to autism therapy services with our data and our research.
Thanks, that was great. She had no voice last week, so this was great. All right, so that was your first objective. On to the second. and that is to understand what we're doing in the neonatal follow-up and some of the outcomes of these children that are born at high risk. I'd like to point out our team members in the neonatal follow-up clinic. Keep in mind that the beauty of this clinic is these are the same people for the most part as the child developmental clinic. So same psychologists, same occupational physical therapists, nursing staff, physicians. So we have a lot of communication and coordination for those children who need either or service. I did want to highlight one person in particular is that we are just so grateful to have Dr. Betsy Ostrander to be part of our clinic. I think it provides a continuity between the NICU and our clinic, and I think enhances the services for these kids in a tremendous way. She and I actually are part of an initiative, a national initiative on the new process for diagnosing cerebral palsy, so stay tuned. I'm not going to tell you about that now, but February 14th, Joyce has given us another opportunity to present that information to you. So we're not going to talk about that today. It's important before we review the data to understand who are these children that we're evaluating. And this is our criteria for enrollment. We are seeing children that are equal to or less than 1,250 grams or equal to or less than 26 weeks, either or. We also see children that required ECMO and children that have had HIE, some of whom have been cooled. We also do see, and Wendy Evans and I review some of the referrals that come in that don't meet that criteria. There's occasionally times where people really need to have those kids seen, and we will do that. But also know that if there's children that are born early that you're worried about that are relatively far outside of our criteria and we can't see them in the NICU follow-up clinic, we do see them in the child developmental program. So it's not like those kids can't be seen, even if they don't qualify for NICU follow-up. We have a little carve-out program in the child developmental clinic where I do arena assessments with either our occupational therapist or physical therapist, so we can see those motor delays in those young infants rather quickly now. We have a minimal waiting list for that program. So we do have that opportunity if they don't meet the criteria. So I don't want you to get the sense that, well, there's just nothing we can do, because we will see those kids, just not in this program. The other thing is critical for your understanding of this data is to understand how we come up with the data and what our schedule is for seeing these children. Note this, you don't have to memorize this table by any stretch of the imagination. I give it to you to give you the sense of the longevity from 3 months to 4 years of age, as well as the complexity and the depth of the evaluation that these children give. For those of you who don't live in the world of NICU follow-up, this is extremely robust clinic. This is extremely in-depth as well as lengthy. Many NICU follow-up clinics follow the children until 2 years of age, and we have been fortunate to follow these kids till 4 years of age. So that is definitely a strength. We right now are getting our support from the Department of Pediatrics at the University of Utah. It's important to realize that all NICUs in the state of Utah can send their kids to us. That has been a long history, starting with the Bureau of Children with Special Health Care Needs for a long time. And that's historically why we've seen every kid from NICUs, is because that's what the health department's program was. That presents a unique opportunity and a unique situation where you're not just seeing babies from one NICU, you're seeing babies from all NICUs. But right now, all of that support comes from the Department of Pediatrics, and we hope that changes. So this is the start of the data. I don't want you to get overwhelmed by the many numbers and lines and graphs and charts. We got some big picture concepts. What I'm going to show you are screenshots of a program that those of you who are really interested in this data can be able to access. And if we have time, I'm going to show you the live version. We'll see about our timing. But this isn't the larger view of how many children we have seen. What we're looking at is the children that we've seen in 2015 through 17, but their birth dates are 2010. So we go back to 2010, and we've included all data up to 2017. So that's 1,079 patients, and you can see the breakdown of the hospitals from which they are discharged. But if we were in the live version, I could change this easily over to the birth hospital, and data would instantly flip. So this is the discharge hospital. As you can see, our largest percentage are coming from the University of Utah, but the IHC facilities together are also a very large percentage of our patients. The pink, obviously, is female, and blue, male, kind of clever. So you can see that. And then we are including, you can see down here, we could select out, we have very small numbers from other states, but if we wanted to look at just state-specific, we could do that as well. Here's our distribution of patients by gestational age. That is obvious because that's our criteria. So you can see that we have a large number of extremely young patients, and then we also have a bump in the term patients, and those are probably going to be the kids with HIE or the children who needed ECMO. This is showing the distribution by birth weight. Many of you are familiar with these categories. Extremely low birth weight is less than 1,000 grams. Very low, 1,500. Low birth weight, 2,500. Normal is up above 2,500. And those are standard definitions of distribution. As you can see, most of those children are average for gestational age up in the corner. So I wanted to better understand what percentage of the whole do our kids represent. So what we did is, with information from the Utah Department of Health Vital Statistics, from birth certificate records, we were able to obtain how many children were born in our low birth weight criteria group. So this is the 379, 78, and 92 data is from the Utah Department of Health Vital Statistics information. They do not have the mortality rates. So kindly, I went out to Dr. Yoder and Dr. Lang, and they gave me the information from these sites. And on average, this was the mortality rate. So if you really, the percent of total here, the first number is the percent of total, but when you consider the percent of those who are actually discharged, we're roughly looking at 50% of the children that are eligible for our clinic. So I think that helps you understand where this how many patients does this data represent. The other thing I wanted to talk to you as background, Dr. Yoder knows this oh so very well through many meetings, is the Neonatal Research Network, and we are one member of this large network across the country that follows outcomes, defines impairment and in these ways. So before the psychologists in the group have a heart attack or start throwing rotten tomatoes at me, let me please explain to you. And the reason why I'm going over this is because I'm presenting the data and the subsequent slides with this information, with the cutoffs and the decisions about how we describe impairment. This is also, for those of you who love to read outcome data literature, the language and the terminology and the divisions that they describe neonatal outcomes. So the Neonatal Research Network is saying that there's that to be in the normal category for the Bayley 3, okay, and we'll talk about the Bayley in a second, but that's a cognitive developmental test. A typical or score would be above 85. They are calling moderate neurodevelopmental impairment 70 to 84. And this is where I'm looking at Sean and Ashley and they're going, because that's not the definition for a psychologist. But this is what the NRN has decided, the Neonatal Research Network has decided is moderate impairment and severe impairment less than 70. Same definitions for motor skills. The GMFCS level, let me talk to you about that. That is the Gross Motor Function Classification System. It is a functional description, and I'm seeing Kilby nodding here, functional description of cerebral palsy. And for those of you who work with kids with cerebral palsy, I'm making a plea to please use this categorization because it tells you about function, with the level 1 being children who have abnormal gait but need no supportive device, all the way up to level 5, in which they need assisted mobility, such as a wheelchair, and they are not able to move that wheelchair. Vision, as you can see, they used blind and hearing impairment with or without amplification as the cutoff. So it's important to understand that and understand that there is controversy about this. So here's our Bailey 3. And again, we're using the Bailey 3. That's going to change to the Bailey 4, which gives everybody heartburn, just like moving from the Bailey 2 to the Bailey 3. But the Bailey, keep in mind, the Bailey is a developmental cognitive test. It is not an IQ test. It is developmental. So it's a point in time. And many will say, and there's data to support the fact that it's not a stable measure of cognition. So as long as we understand that we're just looking at the children's cognitive development in the moment in time, what we're seeing is that many of our children have cognitive delays. No surprise there. So what we're seeing in our sample, okay, this is not the Neonatal Research Network now, this is our data. We're seeing that roughly a quarter of the kids have cognitive impairment as defined by the Neonatal Research Network. And then what I find fascinating and what's unique about our clinic, if you look at the language scores, over a third of the children have language delays. What is unique about that is that we actually have that information. Many follow-up clinics don't have speech-language therapy and don't know this kind of information about their kids. So we're real proud of that. And then the motor score is also a third of the kids have motor delays. Now, what I wanted to look at is, well, then what does our data show about whether those children remain stably cognitively delayed? And at the 4-year visit, we've done WIPSEs. And for those of you guys who don't know that, that's the Wesker Preschool Primary Scale of Intelligence, which is why we say WIPSE. It's a lot easier. That actually is an IQ test that is done at 4, and that's one of the beautiful things about our clinic is we can see the kids at a time where we can do cognitive testing. We are transitioning over to do a school readiness test, so we don't have as many children with a WIPSE score, but we still have that capacity to do it. And what you can see is that in our overall group, okay, remember this is the overall group of our kids, we actually saw a preservation of that roughly 1/3 of the kids who now have an IQ that is less than 85. That is not cognitive impairment. Remember, cognitive impairment is defined as an IQ of less than 70 and an adaptive score less than 70. But these are kids that are gonna need help in school. They're gonna need supports. And that's a lot of our children. Again, not a surprise to those who work in this field. So one of the other things that the network likes to follow, so I wanted to look at it too, is how are our kids doing motorically, and what are our rates of CP? This is our overall group, and that's 13.3%. That's not different than national findings. That's roughly in the ballpark. You can see the distribution of types of cerebral palsy. I'd say that this particular snapshot is showing more kids with quadriplegia than the overall data would show. Usually it's a third, and a third between quadriplegia, diaplegia, and hemiplegia. If you look at this unknown category, this is either we don't know or we didn't describe it, and so the data couldn't pick that up. I would suggest that it's probably the latter. Or mixed, because a lot of these kids, for those of you who work with kids with cerebral palsy, know that they don't come in categories. They come blended, as much biology is blended. So they emphasize vision impairment as a neurodevelopmental impairment. We are not seeing many kids with vision impairment. You can see that we've got just 15 kids with blindness. Now, this, mind you, this is not the high, myopia. This is blind. Blind in one eye, blind in both eyes. So these are the severe vision impairment. Same thing with sensory neuro, and I just selected out for sensory neuro because I think the conductive is just a messy set of data. So the sensory neuro and hearing impairment is also not large, but a significant problem when it does happen. So this slide is kind of overwhelming. The blur of information in your upper left-hand corner just shows you we are collecting a lot of information on these kids. What I wanted to do with this particular slide is show you, tell me the story about these children with cerebral palsy. I want to know a little bit more about them. What is their gestational age? You can see they're highly clustered in our real young children. And then what is their weight distribution? Again, our very extremely low birth weight. What I find fascinating is this program can also pick up a median age of diagnosis. And I think that's really important. And again, stay tuned for the February grand rounds, but we are really trying to move that age of diagnosis up earlier. This particular age of diagnosis is roughly 22 months, which is lower than the national average, but not where we want to be. We have done an initiative where we've actually, since tabulating this 2017 data, we're closer to 12 months now, based on the initiative that Dr. Ostrander and our group is taking on. So let's look at autism. And this brings me back to that point I made earlier where remember that the psychologists and the therapists are the same people in the child developmental program where we're diagnosing autism. So I think the validity of the diagnoses in this database is as solid as it gets. That's one of our strengths. Unfortunately or fortunately, we can find this information. This is slightly lower than the national average that Dr. Q just said was 52 months, but still not where we need to be in terms of getting the best kind of outcomes with ABA therapy. But that's where we are. And I think people are not surprised that we have a higher prevalence of autism in this group of kids, but I did try and calculate that for our database, and it's not the same as the ADAM network or the Utah database for autism, but it is a slice of children, our high-risk kids, that are saying essentially we've got 3.9% prevalence, and the prevalence in the paper that Q just referenced was 1.7%, and that's 8-year-olds. These are our group is the oldest kids are 4 to 4.5. So no surprise, it's a lot higher in preemies based on our database. So we also want to look at that slice of children that are on the right-hand side that are higher birth weight, and those are kids with the HIE. We have roughly 25 kids in this database, and keep in mind that not all of these tests have yet been done on these kids because we're using birth dates to look at them. So some of these kids aren't 2 yet, so they're not going to have a Bailey score. It's a moving target. This is why the wealth of this database is it's ongoing. We are continuously feeding data into this. So this is how our kids with HIE are doing for the information that we have. And then we also looked at kids with ECMO, but we only have 16 of those kids. I asked Dr. Lang to find out how many kids that have been placed on ECMO. It's 120 kids, but many of those kids don't survive to discharge. So this is actually representing a smaller percentage of kids with ECMO. So it's an interesting question about, are we getting all those kids? Why aren't we getting those kids? That kind of thing. But of the kids that we've seen, one has CP. You can see higher percentages of language problems, and there were, as you can see down here, we've got one child with hearing impairment and no children with vision impairment of those kids that we looked at. So, I want to have ample time, and it looks like we do, to show you the live version of the program. You've just been seeing screenshots, and I just want to have you see the capability of this. But before we do, I want to make sure that I give a big shout out to Wendy Evans, who's sitting here, who has done so much of the data entry. She's working with Kyle, our data analyst in the quality team, to make this more automatic and have it directly feed from Epic. But I'd also like to thank Dr. Yoder, who's here with us today, and Dr. Ling, who helped gather some of the important information for denominators. And also Lori Baksh of the Department of Health, who gave me the vital statistics information. But most of all, we just thank every day the fun and the funny, cute little folks that we see. I feel like I have the best job in the world. These kids are just so much fun. We like to collect things that they say. It's just priceless, as you all know. You're all in pediatrics, so you all know that. Let me now pull up the live version. And I'm really not a inherently data person. So I find it fascinating that I'm just so excited about a database. Who would have ever thought me be excited about a database? But this is what it looks like when you have access to it. And we are working, obviously the folks at the U, like Dr. Yoder, you have access, you're free to roam around in this database. We are working with with IHC to establish contracts for data sharing with them. So hopefully they too will be able to roam around in this database. But let me just show you. So if you come in, you're going to get this pretty welcome dashboard, and then some descriptions of our clinic, data definitions, which isn't loaded yet, and then you get to the actual data set. So I could change this. What if I could say, you know what, I don't want to see 2016. I don't know why I would do that, but it moves. I just want to see how the kids just from the state of Utah are doing. I just want to see that this is amazing little thing that you can slide this and say, okay, I just want to see the kids that were under, I don't know why I do this, but under 30 weeks. So it's an actively changing, responsive to your query kind of database. And we have finished 2017. We are entering and close, right, Wendy? Close on 2018. And what we anticipate is pushing this data out, depending on what our users want, pushing this data out to on a 6-month basis. It's not going to be like ongoing because we need to clean it and make sure it's we don't have any errors in it. But this is now a chance for you to ask questions either about the autism, or pediatricians as first-tier diagnosticians on autism, or ask us questions about this data. I'm certain that there will be a few questions. Okay. Joyce has the microphone.
Get their thoughts together. No? They're thinking.
I see Jim, and then there's a gal back there. Yeah.
Sarah, I had a
Dr.
question
Beck.
really about your longitudinal follow-up relating to the Bailey data, cognitive outcome, and the WIPSI data later at 4 years of age. Are those the same children, or do you see some children who become impaired over time and others who normalize over time?
So great. I knew we have such smart people in the audience. So not the same database. So the first slide I showed you were those kids that are 2. So the Bailey is done at 2, and the WIPSI is done at 4, and we have attrition. So we were talking about one of the potential research questions in this is why do people decide to leave the clinic? Do we have a group of families that feel like their children are doing well, and so they don't need to continue to follow up, and so we're skewing for more impaired children over time? Or, you could hypothesize, it's just total hypothesis, that they don't want to continue to come hearing negative things about their clinic, so they stop coming. So it could skew it either way. We don't know. We really don't know.
Was there a hand up on this side?
Yeah, this,
I was just curious about hearing more about the process or the resources available for community general pediatricians in terms of training for autism diagnosis.
do you want to handle that one, Paul? I think she's asking about our certificate program. Let's, Joyce, do you mind bringing the microphone down to Dr. Carbone?
Hi, I'm Paul Carbone. Well, we have a couple of initiatives. The certificate program that Sarah has mentioned, we've had a couple pediatricians roll through. The program as it exists currently, or what we've done, has a member of our division at first, but we are certainly able to craft that to accommodate the needs of a pediatrician in the general community so that we could train up a pediatrician in the community. So that those opportunities are there, and we'd be happy to do it. I think one of the things that we're all realizing in this field is that the volume of children, we got our, as you saw, we got our time to diagnosis down. It crept right back up. And the reason is like, it's like no good deed goes unpunished. So as people hear about us, we get more and more referrals. I think we get 50 referrals per week. With our, mighty team, we're small and energized, but we just, that's a huge volume. So we're definitely looking into care process models that sort of expand our operation into the community, and having general pediatricians, for example, do the same tests that Q and Kendra Leistad, who's here, and I and Sarah do in the clinic, namely the level 2 screener like the STAT, is something that we're sort of initially branching out to our own clinics within the university system and training up some pediatricians in those 2 locations. That's being led by actually one of our residents, Kathleen Campbell, who I'm not sure is here. She's probably oh, there she is. So, so there's opportunity, and certainly let us know if you have the drive and ambition, and we'll accommodate.
Here, Paul.
I have a bunch
Chuck,
of
yes.
questions, but I'll let you go first.
Just to come back to Jim's question for a second. So for those kids who you do have, a Bailey and then a WIPC, how much correlation between degree of impairment are you finding?
Yeah, and that would be a carve-out kind of look that we could do, and an important look, because that has been done, and you can see in the references that were given in your handout, there's a 2005 paper that in which Maureen Hack had looked at that in their group of kids, which is the Neonatal Research Network, and about half the kids changed over into the normal range when they did the WIPC, or I think it was a WISC, but anyway, when they did a full cognitive test. So that's better data than what I just presented to you. But we could look at that, and that would be an important little sub-look. The other sub-look that Jim kind of alluded to is I want to know why. So we get roughly 50% of the kids that are eligible for the clinic. I think it'd be fascinating to survey a group of those to find out, well, why aren't they coming? Are these kids more involved than the kids that we're seeing? Or, I mean, by involved meaning more that have more challenges, more developmental issues, or do they have less developmental issues? Or are they is our sample very representative of the whole? We have theories going both ways, and like many things, it's probably many reasons, but I'd like to understand the predominant reason for not coming. The thing that, that I want to communicate, and this is my chance to say this, is neonatal follow-up clinic is important for these babies. Everybody, I think people generally know that, and I understand that. I'm now preaching to the choir, but we do get some comments from families, and it's hard to know if that's communicated accurately, but that my child's doing well, why do they have to come? Well, first of all, you don't know if your child's doing well. They're just 9 months, and we don't have language yet. We don't have the social, 9-month-olds have beautiful social skills, but they haven't fully developed their social skills. There's many developmental realms to be tested. There is no pediatric office that has the bandwidth to do the kind of broad developmental testing that we do in our clinic. So it is sort of a false sense of security, I think, to say, well, the baby lived and, they're not having medical problems, therefore we don't need to come. And I feel like pediatricians and other primary care providers can re-emphasize to a family that this is a tremendous, rich resource for your family, and there's many opportunities. As you can see all the visits we have, 3 months is to look for CP. 9 months is to also look for CP. 18 months, we're looking for language development. 24 months, we're looking for signs of autism. 3 years old, we're looking for behavioral challenges. And 4 years old, we're looking for school readiness. It's different every time. There's a different reason to see these children at all the different time periods. The schedule has been carefully crafted by the experts of clinic. And I see Dr. Bodner back there who used to do this work. There's a reason for each one of these visits, and it's a rich resource. And I want to say, send your kids, even though, yes, we're busy, but I can't tell you in clinic, every day we see families that we recommend something, either speech therapy or further evaluation. And the nice thing about our clinic is when we see some social skill difficulties, then we refer essentially to ourselves, back to ourselves to do the autism testing. That takes, yet again, a very long, much more time than we have in the neonatal follow-up clinic. see
One of
your
your
question.
slides showed that you use the WIPSI-R. Is that really what you're using, given we've had the 3 and 4 out since then?
So, thank you very much. I knew, thank you. This is a question for our psychologist. What are we using? Sorry, that was my typographical error. Dr. Cunningham's saying that we use. You just,
We use the most recent edition. So, yeah.
thank you. We'll change that for my next presentation.
I just wanted to reiterate, Sarah mentioned that the department financially supports the neonatal follow-up program, which is great, but that means there is no out-of-pocket expense to the parents, and I think that's important to know. So they need to know that. We do bill their insurance and we bill Medicaid, but we do not balance bill patients for the neonatal follow-up program.
Or the Heart
Or the
Center
Heart Center,
Neurodevelopmental
yes.
program, which we're not talking about today, but we'll just mention that.
Karen's having a heart attack over here.
That's not the child development. I mean, in
Yeah.
child development, we have a sliding fee scale for child development program. And I would just make another pitch that even if you think your NICU grad who was had these high-risk criteria is doing well, the program and its database is enhanced by kids who are doing well. I mean, if you really want a good representation of what 26-weekers that come out of the university NICU look like, we need everybody to come back and enrich the database so that we can give more accurate results to our families. Or when you're counseling the woman in labor at 26 weeks, you can give her accurate information about outcomes.
Is there an automatic referral from the NICU? I'm not working there, I don't know. Is that part of the discharge plan?
Dr. Yoder, you want to
Neonatologists
comment?
are shaking, yeah.
We have our
Hold on, Brad.
head of the Division of Neonatology here is going to comment on that.
So it's supposed to be, yes. We hope it is. We, as part of the network, and it's not just the university that's part of this network, Utah Valley, McKay-D, and Intermountain are all, and the primary children's are all participating sites from Utah for the Neonatal Research Network, which has 15 sites across the country. We have probably 85 to 90% follow-up from within the sender sites because we have a team of people who specifically go out and beat the bushes to get them in. So if it's 55% overall, I think that means we're losing a lot of probably more community babies, and we don't have access to them, but a lot of the pediatricians may have access to them. So I would actually advocate, yes, like Karen said, we would like, if you see some of these patients in your clinics, that you should actually ask, are you going to the developmental follow-up program? And if not, you should, because it won't cost you anything.
I'm coming to you, Paul, but as I walk somewhat slowly, how about telehealth? Have you thought about that for some of these more rural areas? Is that a Pandora's box?
So the UDAC is doing a huge amount of work in telehealth. What's our latest number? Do you have, Lori? About 500 telehealth visits are done in the child developmental program. However, our therapists and psychologists and I had a rich discussion about how would we do telehealth on a 9-month-old, and I just can't figure out how to feel tone over the TV yet. So we're exploring it, but we're not there in the neonatal follow-up clinic. Dr. Young, did you have a question?
Yeah, so sort of a comment and a bit of a follow-up on Karen's point. So neonatal follow-up programs have two purposes. One is to identify kids and get them into services. The other one is to evaluate NICUs, how they're doing. That's really where those programs came from, was what's happening. So my question for somebody, and maybe Brad could, that's been looking at this for a long time, are we doing any better with kids that are under 26 weeks? When I was in medical school, 28 weeks was the limits of viability,
I
let
know.
alone good outcomes.
Yeah.
So are the neonatologists doing better with kids that are in those first two bullets?
Yes, yes. So I'll say my piece, and Dr. Yoder, you say yours. So I'm the site developmental follow-up person on the Neonatal Research Network. Dr. Yoder is our site PI. So we sit in meetings when we go nationally and find out sort of the trends overall. One caveat before I answer your question is it's important to know how your NICU is doing, because when you look at the data overall, there's quite a bit of variability from center to center. So when Dr. Yoder is going to talk to her, or when Dr. Gulliver is going to talk to her patients, she needs to know how patients do at her site or at his site, not how the NRN does. But the NRN does have data about how kids are doing overall. I think in the CP rate has kind of plugs along, rocks steady. But what the follow-up PIs are noticing is we have less severe CP. So I'm actually a little bit disturbed about the rate of quadriplegia that we have in our data set, and I'd like to watch that over time. But we do see a lot of these kids that are, that would be a level 1 GMFCS, gross motor function classification. The other thing anecdotally that I'm seeing, and I don't know that our HIE data is robust enough yet, but I am a firm believer of HIE cooling protocols, because I think we're seeing a lot less kids with problems from that. That's my impression. Dr. Yoder, you give your feedback.
I'm surprised they actually had a NICU back then.
Ooh, ouch.
Yeah.
Dr. Young says they didn't.
Yeah. Well, I think, having been in practice for too many years in the newborn ICU, I think the emphasis we have is on doing anything and everything we can to improve the brain function of all the patients that we take care of. We've made dramatic improvements in survival all the way down to 23 now. Even some people are pushing into the 22-week category. But still, we want to make sure that what our hope is always is that not do we just have a good survivor, but an intact survivor. And so all of the research that I would say 90% of the research we apply within the network is focused on developmental outcome. If you cannot get a study in our network going without having developmental outcome as a primary or a key secondary endpoint. In fact, they all basically say developmental outcome is part of that thing. So is it improving? I think it's improving. It's definitely improved over my course of time, and even within the last 10 to 15 years, we can continue to see improvement. hopefully we don't have a ceiling, but we may have a ceiling we can't get beyond, but we continue to push towards trying to get better outcomes. I think CP is significantly lower personally than what I remember in the past. We have a lot less problems with bleeding in the brain. Cooling has been an incredibly important therapy for the HIEs. We're now adding in additional interventions with cooling to see if we can further improve those types of outcomes. And some of those things, such as erythropoietin and darbepoetin, have actually migrated now down into a trial we're doing in very preterm infants to again see, can we augment and improve developmental outcomes? So it's getting better, I think. It's better certainly than it was when we first started. And I hope that, the hope would be we could make it go away completely. I don't see that as happening, but we will continue to push forward with that.
Thank you, and it's, yeah.
We have come to the end. I'm sure this
Come to the end.
great
I'll
group
stay.
would take questions offline.